Hi, everybody. Thanks for joining today's NCCN patient webinar, Know What Your Doctors Know About Prostate Cancer. This webinar is presented by NCCN. NCCN stands for the National Comprehensive Cancer Network, which is a not-for-profit alliance of more than 30 leading cancer centers across the United States devoted to patient care, research, and education. There's also the NCCN Foundation, which is a nonprofit organization that raises funds for NCCN patient resources, including new and updated patient guidelines, as well as patient webinars like this one. These resources are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. Our guidelines for patients explain the same options for cancer care as our clinical practice guidelines, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines for patients from the NCCN website, or printed copies of the books can be purchased through Amazon. The Know What Your Doctors Know webinars complement the NCCN guidelines for patients. And now I'd like to introduce our three presenters for today's webinar. Our first speaker is Dr. Tumor Lotan. Dr. Lotan is a urologic pathologist and researcher and an associate professor of pathology and oncology at the Johns Hopkins University School of Medicine. Our second presenter is Dr. Todd M. Morgan. Dr. Morgan is a urological surgeon and researcher and professor of urology at the University of Michigan Rogel Cancer Center. Our third speaker of today is Mr. Stan Rosenfeld. Stan has been a longtime patient advocate for the UCSF Urology Patient Services Committee, and Stan also runs the Marin County Prostate Cancer Support Group. And now, without further ado, let's hear from our first presenter, Dr. Lotan. Dr. Lotan, the floor is yours.
Thanks very much, Sean. Thanks for having me here today. So I am going to tell you a little bit about the pathology of prostate cancer. And we'll talk a little bit, to begin with, some introductory thoughts about, where the prostate is located, as I'm sure many of you are already aware, and what it does. So the prostate is located just beneath the bladder, and it secretes a fluid that mixes with the sperm, which is produced in the testes and helps the sperm to survive during reproduction. This is important to know because prostate cancer is often diagnosed, or most frequently diagnosed, by taking a small piece of the prostate called a biopsy, and usually that's done by a needle biopsy, either through the rectum or through the skin. And all of the tissues that are removed from the body, either by biopsy or by surgery when prostate cancer is eventually treated, are examined by a pathologist. So pathologists are really behind the scenes doctors, and many of you have probably never met a pathologist, and we don't interact directly with patients. We mostly interact with other clinicians, especially surgeons like urologists. But every diagnosis of prostate cancer is made by a pathologist, and some of the analysis that we do of that tissue becomes very important in selecting treatments down the line. So pathologists receive these tissues, usually prostate needle core biopsies or prostatectomy tissues after surgery, from the urologist, and we examine them grossly. That means without a microscope, just looking at them on the laboratory bench. And then we decide which pieces of tissue require microscopic examination. So for biopsies, we will typically examine the entire biopsies, all of the tissue that is removed by the urologist. And for prostatectomy tissues, many centers will examine all the tissue, and some centers will examine only some of the tissue. Depends a little bit depending on what institution you're seen at. And what happens to that tissue, just to sort of make some of the slides that I'm going to show in the next, a little bit later in the deck make sense, that tissue, after it's examined, is fixed so that it's preserved, and it can last for, decades, even hundreds of years. And it's dehydrated so that the water is taken out of it and essentially embedded into a wax block. And that allows us to kind of stabilize the tissue so we can take a very, very thin slice of tissue off the top of that wax block and look at that under the microscope. We need a very thin piece because we want to be able to sort of see through the tissue. We need light to come through the tissue so we can examine it under the microscope. So those are slides that we look at under the microscope. And that's where a lot of the analysis of the prostate cancer cells, both the diagnosis and then the downstream analysis, grading and staging, is done by pathologists. So we're looking at a very thin piece of tissue off of the top of a larger piece of tissue. So the main role of pathologists, sort of behind the scenes, is to diagnose prostate cancer and then also to grade and stage it. And we'll talk about what each of those means. So diagnosis, is really just looking at the piece of tissue to say, are there cancer cells in that tissue or not? And you can't get a diagnosis of prostate cancer in general unless a pathologist has looked at that tissue under the microscope. And usually those are biopsies of the prostate. As we mentioned, they can be either rectal or through the skin, which is called transperineal. Occasionally, patients have procedures, usually for benign prostate enlargement, where larger pieces of tissue are removed through the urethra. This is called the transurethral resection of the prostate, or a TURP specimen. And once in a while, we find and diagnose cancer in those because we also look at those under the microscope, just to make sure that there's no cancerous growth. And then once in a while, patients present actually with metastatic tumor that's spread beyond the prostate, maybe to another site, bone, or some other tissue site, and we can look at the tissue under the microscope and tell the urologist or the treating doctor if that tissue is likely to have come from a prostate cancer. So that's kind of the diagnosis side of things. In terms of grading, that we're going to talk about in some more detail because that's so important for treatment. But grading is done by examining the tissue under the microscope and essentially ask the question of how similar the cancer cells are to normal prostate tissue. Essentially, the more similar they look under the microscope, these cancer cells, to normal prostate tissue, the less likely it is that that tumor will be aggressive. And grading, and we use a system called the Gleason grading system, which is named after the man who originally described it back in the 1960s, is one of the best ways to determine if a tumor is likely to be aggressive or not. It's not perfect, but it's one of the best methods that we have right now. I want to distinguish grading from staging. Staging is different and asking a question of not how does the tissue look under the microscope, but how far has the tumor spread? Is it confined to the prostate itself, or has it likely spread beyond the prostate? And there are two different staging systems. One is a pathologic system that pathologists do by examining tissue under the microscope and looking at microscopically how far has it spread. And then there's another staging system, which is clinical, where urologists and oncologists and other clinicians, radiation oncologists, use imaging studies and physical exams to try to discern how far the tumor has spread. And I'll tell you a little bit more about pathologic staging in the next few slides. So stage and grade are often correlated, meaning that the higher the grade of the tumor, the more aggressive it is, the more likely it is to have spread outside of the prostate, but they're not 100% correlated, so that there really are independent variables. Okay, so prostate needle core biopsies, we talked about, are these small pieces of tissue that are typically used to diagnose prostate cancer. And the vast majority of the diagnoses we make in pathology are made on the needle biopsy. And I don't know if you can see here using this, this ruler to give you a scale. These are very small pieces of tissue, very thin pieces of tissue. They really fit within the bore of a needle. That's how thin they are, about 1 millimeter thick, and maybe 10 millimeters or 1 centimeter long. And they're typically taken in two different ways. One way is to just randomly sample different zones of the prostate with these needle biopsies. Often we get 12 separate needle biopsies that the clinician takes, and it's actually done just by sampling different parts of the prostate, not based on, you know, where we think the cancer is, just to get a random sample and see if any of those tissues do have cancer in them. Or the biopsies can be guided by imaging, which is a relatively newer technique. And typically we use MRI imaging, a special type of MRI called multiparametric MRI, which often shows areas which might be more likely to have cancer in them. And the urologist can sample those areas specifically and get additional tissue from those areas. Typically, they also do additional random sampling just to make sure they've covered the whole prostate. And I think this is one of the key take-home points of this discussion today, because we're only sampling these very small pieces of tissue from the whole larger prostate. We really can't be sure exactly what the whole tumor looks like. We're going to look at these pieces of tissue under the microscope. In fact, we're often just taking a tiny piece off the top of these larger pieces of tissue, and then maybe some additional sections deeper through it. But we're only able to look at these very small pieces. So we're hoping that these are representative of what's happening in the larger prostate. This is just a microscopic slide, or a microscopic image of a slide of a prostate needle biopsy. Again, sort of giving you this idea of the scale. This is just a centimeter long here. So you can see how very tiny these biopsies are. And the pathologist is looking at this under the microscope to see if there are cancerous cells within these biopsies. So the grading system for prostate cancer, as I mentioned, was started by a physician named Gleason back in the 60s. And it's changed somewhat over time. And some of those changes have made it a little bit more confusing. So I hope I can help clarify some of the aspects of the Gleason grading system in this talk. As I mentioned, the grade is where we're just looking under the microscope to see how much does the tumor tissue look like normal prostate tissue. And the way that this was originally conceived is that normal prostate glands are pretty round and circular, kind of like these little circles that you can see here. And so the lower grades, in the original Gleason system, it actually started at grade 1 and went up to grade 5. The lower grades look more like these little round circles. And you can see as you get through higher grades, or higher patterns, I should say, pattern 3, pattern 4, pattern 5, the cells start to make funny shapes that no longer resemble kind of these nice little O's or circles that the normal prostate tissue looks like. What makes Gleason grading a little confusing is that over time, since the 60s, we actually eliminated these patterns 1 and 2. And many of you may have noticed that in your pathology reports that we only report pattern 3, pattern 4, and pattern 5. So the lowest grade pattern you can have is pattern 3. And what makes it even a little bit more confusing is we report both the most common pattern and the second most common pattern that we see under the microscope. So in any biopsy that's graded, the actual grade is a sum of the most common pattern that we see under the microscope, again, starting at pattern 3 and moving up to pattern 5, and the second most common pattern that we see under the microscope. So sometimes the whole tumor might be very low grade appearing. It's all pattern 3, so that would be 3 plus 3, and then we give it a sum equals 6, prostate cancer. And that's actually the lowest grade, the cancer that looks the most like normal tissue and is the least likely to be aggressive based on what we see under the microscope. And then, as you could see, you could have multiple other combinations. You could have pattern 3 as your most common pattern, but a little bit of these more peculiar looking shapes of glands under the microscope. And that might be 3 plus 4, etc. Just to make things a little more confusing, though, that we've over time changed a little bit how we report these different patterns in needle biopsies. And since probably 2014, 2015, we've been pretty, it's been pretty fixed. But, patients who had a diagnosis before that, which is probably not very many of you, might have had a little bit different, might have had, for example, patterns 1 and 2 on their pathology report, which we no longer report. And as I mentioned, the reason grading is important is that we think it's one of the best predictors of how aggressive a tumor is likely to be. Okay, so here's how some of these patterns actually look under the microscope. So when we take a very thin slice of the biopsy and we look at it under the microscope, we actually stain it with a couple dyes that help us look at different parts of the cells under the microscope. The blue dye highlights the nucleus of the cell where all the DNA lives, kind of the instructions for reproducing the cell. And the pink dye stains the rest of the cell. So the pink, and it stains also muscle tissue, which looks pink. So that's why you kind of see these blue circles, which are the cancer glands here, and in kind of a pink background. And this is just to give you a sense of what those shapes I showed you in the cartoon before actually look like under the microscope. So these are pattern 3 glands. You can see they're round. They have these white spaces in the center, and they more or less look like a normal prostate gland. They're very round and circular and regular looking. And then you can see that as we look at more aggressive tumors, pattern 4 or pattern 5, the cells stop making these neat little circles and start making these more complex shapes. And by pattern 5, they make almost sheets of cells where we can't really discern any real shape. And these are more likely to be more aggressive because they have essentially lost, these tumor cells have essentially lost some of the instructions for forming these normal glands, and they're sort of behaving a little less like normal prostate cells. So as I mentioned, we give each case 2 different patterns ranging from 3+3 up to 3+4, 4+3. You can have 3 different combinations that sum up to Gleason score 8. You could have 4+4, 3+5, 5+3. You can think of sort of all the different combinations. And then various combinations of patterns that sum to Gleason score 9 or 10. So the sum, the Gleason score, can range from 6 to 10. And I hope I wasn't too confusing, but the reason why we have this weird system that starts as its lowest at 6 is, as I mentioned, because we used to have these patterns 1 and 2, but we no longer have those anymore. To make this a little simpler, we've, in the last 5 years or so, started reporting these as, instead of Gleason scores, we translate them into grade groups. So we can start at 1 and end at 5. And we group some of these different combinations together because they behave pretty similarly. So tumors that are 4+5 or 5+4 or 5+5, have subtle differences in the way they might be likely to behave, but they more or less comprise the most aggressive group of tumors and the very highest risk group of tumors. So we sort of lump them all together into grade group 5. So there really are 5 tiers here, ranging from the lowest risk tumors, where the tumors look the most like normal prostate tissue, to the highest risk tumors, where they look the least like normal prostate tissue under the microscope. And as I mentioned, this is tends to be highly associated with risk, but it's not perfect. And it's not perfect for many reasons, probably the biggest one being that when we sample only a small piece of tissue, we don't really know if we've sampled something representative of everything that's happening in that prostate tumor. So we might get a sample of tissue on the microscope that looks like grade group 1, but it could be that nearby to that tumor, but not hit by that little tiny needle biopsy, there's another area that has a higher grade tumor. That's unlikely, but that's not, since we're not sampling the whole prostate, we can't be 100% sure. So that's just something to keep in mind. So that was a little bit about needle biopsy. So I thought I'd also talk a little bit about examining the prostate after surgery. And so this is how the prostate looks when we receive it from Dr. Morgan or another urologist, and we ink it. We ink the outside in these different colors. So that's why you're seeing these kind of black color on this prostate. And that's so that we can see under the microscope, we can look at that ink and see if the tumor is touching that ink and make sure the surgeon has really removed all of the cancerous tissue. And we slice up the prostate into all these slices you can see here. And when we look at it grossly that means without a microscope, it's actually very hard to see the cancer. In this case, the cancer is just right here on the right side of this image. It's a little bit yellowish and kind of irregular, but it's very hard to be 100% sure without looking under the microscope that is cancer. So we typically look at most or all of these slices under the microscope to try to see where the cancer looks like. And this is what a radical prostatectomy section looks like. You can see a much bigger piece of tissue. Now it's at least 2 centimeters large. This is just a quarter of the piece of tissue that you looked at here. So we cut it into 4 pieces here. And so this is 1/4 of that. And we would look at most or all of these pieces under the microscope to see how far the tumor has spread, what its grade looks like under the microscope now that we have the whole prostate to look at. So there we become very confident in the grade since we're looking at the entire prostate. We don't think we're then missing really any significant parts of the tumor that might be higher grade, for example, if we're looking at the whole prostate under the microscope after it's removed from the body. And we also look to see how far it's spread. Is it coming into some of the tissues that are outside the prostate? That's the stage again. And then does it touch this black ink around the edge, which lets us know exactly where the surgeon cut. So we know if it's likely they cut through that tissue, that tumor tissue, or did they, cut around it. And depending on how far it's spread, it becomes easier or harder to cut all the way around it. And so after prostatectomy, the grading is actually very, very accurate in terms of predicting outcomes, because there we have the whole prostate tumor to look at and to grade much more accurately than we do on the biopsy. And here we've just shown the different grade groups and the probability of progression after prostatectomy. So the probability that the cancer has potentially returned after the prostatectomy is on the y-axis here, and years of since surgery is on the x-axis. And you can see that when the prostate is removed by prostatectomy and the grade is very low, the chance that it recurs is very, very low, and almost none of the patients recur. But as the grade groups increase, the chances that the cancer might recur become higher. So that's how we know that this grading system is pretty accurate in terms of predicting how aggressive a tumor is likely to be. Okay, so sorry, last slide. I hope I haven't gone too much over my time here. So this is just a little bit about staging, that the kind of staging that we do under the microscope, that's different from the kind of staging that's done with imaging tests like CAT scans or bone scans. And here we look, as I mentioned, under the microscope just to see, is the tumor confined to the prostate? This round circle here is the prostate. This is the prostatic urethra that's kind of moving through the center of the prostate. And this is the bladder. So up here would be the patient's head, for example. And so we look to see how far the tumor has spread. Is it spreading outside the confines of the prostate or even into the surrounding tissues? This is the seminal vesicle, which is an adjacent glandular tissue that's connected to the prostate. And so that gives us these different types of tumor staging. And we combine that with staging of the lymph nodes to see if the cancer is spread into surrounding lymph node tissue or spread to surrounding organs to give the final pathologic stage. Okay, so the key take-home points, the pathologists are sort of behind the scenes, diagnosing prostate cancer under the microscope, but playing an important role in terms of making some prediction about how aggressive the tumor is likely to be. And that helps doctors like urologists and radiation oncologists decide what kinds of therapies patients might be eligible for, or what might be the best therapies, or sometimes just active surveillance. We grade the tumor to determine how aggressive it's likely to be. And then because biopsies only sample a very small amount of tumor, they're not always 100% accurate in terms of knowing what else could be happening in the prostate, but they're quite good now that we have, or improving, I would say, now that we have MRI guidance to have ideas of where we need to look within the prostate for the cancer. And then staging is different from grade and a measure of how far the tumor is spread, but also helps give additional information about how aggressive that tumor is likely to be.
Dr. Morgan?
That's the handoff. That was great. What a thrill, really, to follow that talk, Dr. Lotan. That was fabulous, and I really like. I think that would be a great video for any of our patients who are newly diagnosed with prostate cancer to watch. So I'll be pointing them that direction. I will tell you that we've had a small pilot program going of pathologists providing reports directly to patients with a phone call that patients have loved. I think that's wise because of this, that the detail of the explanation there is so helpful. Well, thanks again for the opportunity to talk with everybody here. This talk really kind of builds on that foundation of stage and grade and moves to these kind of these things we can't see. That, you know, we saw the pictures of the histology of those slides. Those are that even probably those of you, you know, none of you have looked presumably at slides before, but could probably appreciate some of those changes visually. And genetics and genomics is a little bit more abstract because we can't see it, but it's a big topic. It's an important topic in prostate cancer care. And I'm sure it's one that many of you have come across and read about. So, you know, the overarching question is, well, why are we even doing something like this? Why are we looking beyond, say, the Gleason grade and the stage? And there are some key issues that we maybe can do a better job of if we look elsewhere, if we look for more information, and that includes risk assessment. So what's the probability of, say, developing prostate cancer? Prevention is, you know, is the disease risk modifiable? For example, in somebody who doesn't have prostate cancer, can we pick up cues that tell us that they are at risk of prostate cancer and then do something to change that? Prognosis, which was what a lot of Dr. Lotan's talk was about, is understanding how Gleason grade impacts prognosis. Can we get other information to tell us even more about prognosis? Then there's this question of treatment selection. We would really love to be able to tell patients, well, you know, based on what we know about your cancer, this particular treatment would be better for you. And this other treatment might not be as effective because of that information. That's really, I think, what we think about when we talk about precision medicine. And then familial risk and testing. So does what I have as a patient, does that have an impact on my family members? And are they at higher risk? And should they undergo testing? So these are all issues that I'm going to touch on in this talk. So when we look at the prostate cancer continuum, at least kind of an early stage disease, there's the early detection. So guys without known prostate cancer we're trying to figure out how best to detect that cancer early. And we have a whole slew of biomarkers. They're called a whole bunch of blood tests, urine tests that can help us maybe do a better job with early detection. There's the diagnosis and staging. So a patient who's been diagnosed with prostate cancer, say on a needle biopsy, are there tools we can use to better understand their ultimate prognosis? Then after treatment, there's these questions of, you know, sort of what we call survivorship and salvage therapy. Are there things that can tell us that a patient would be benefiting more than another patient from additional treatment? And so in this talk, I've bolded here a few items: Polaris, Oncotype DX, and Decipher, as well as germline testing and where they fall. And these are the genomic and genetic tests that we'll be talking about. So to talk about these, we really have to back up even further and understand that there are some mutations in cells that are inherited. We call those germline mutations. Those are mutations that are everywhere in our body. We're born with these. They're passed down from one generation to the next. And then there's what we call somatic mutations. So these are changes in our DNA that really are just specific to the tumor. So they're changes in just the tumor DNA or just the tumor RNA, and they are not inherited. So these two different features are really important, because when we talk about germline tests, we're talking about finding something that might be inherited, might be passed down to kids, might have been passed down to brothers or sisters. And when we're talking about somatic mutations, we're talking about genetic changes that are generally specific to the tumor. And so these are not inherited. So that's a big difference. And the first topic I want to talk about is what's often called genomic testing or gene expression testing. And so this comes from the current NCCN prostate cancer guidelines. And these tests decipher Polaris and Oncotype. They are testing genes that are not inherited. So these are gene expression tests, meaning they each measure a different set of genes that can be found in the tissue, in that tissue specimen that was sent to Dr. Lotan. And so patients don't need another biopsy. They can actually, we can take, or the pathology team can extract the cells from that biopsy that was embedded in wax, send them off for additional testing. And those cells, inside those cells, these labs, these outside labs that have these tests will extract the genetic material, RNA, and assess specific scores or provide specific scores that then give additional information about whether a cancer might be more aggressive or less aggressive. So those are gene expression tests. You can also see in this chart, so this is a chart of what we call risk stratification, and that's this question of let's say we know what we know about somebody's Gleason score, but are there other ways to better assess whether that patient has a more aggressive or less aggressive cancer? And so in addition to these gene expression tests, you can see that there's all these different acronyms under the clinical category. There are all these tools that actually don't require any other test. We can just use the existing clinical information. And so this is an example of that. This is called the StarCap prostate cancer system. This happened to be developed at the University of Michigan. And you can see on the left, so this is an online calculator, and on the left, we can plug in all of this information that we know about any patient. Patients can even plug it in themselves. And using that information, we can calculate the risk that somebody might be at for dying of prostate cancer, say in 5 years, or dying of prostate cancer in 10 years. And so you can see that this is a patient with primary Gleason 4, secondary Gleason 3, so 4+3 prostate cancer. But in addition to just looking at the grade, we can look at all these other features and combine them and give a risk assessment. And so that moves us from just one dimension to already multiple dimensions. We can also, for some patients, can be helpful to use one of these three tests, Decipher, Oncotype, or Polaris. Again, these are all just different gene expression tests that use tissue. They all have different score reports, and so that makes it confusing, and they all have different thresholds, and a threshold would be some number on that test that we consider separating, a high score from a low score. And so so the tests are slightly different, but basically they're all the same. And if you said, well, which one is better? We would say, from everything we can tell, they look like they perform very similarly in terms of their accuracy for giving us additional prognostic information. And we actually looked in the state of Michigan a few years back and said, so we have access to, through something called MUSIC, the Michigan Urological Surgery Improvement Collaborative. The whole state contributes to collecting anonymous data on patients. And we can say, well, how often are these tests used in clinical practice? And so the way this figure works is each little bubble represents a different practice in the state. On the y-axis is the frequency of sending these tests off in patients who have newly diagnosed prostate cancer. And the size of the bubble is the number of patients that were assessed in that time frame. And you can see that, at least as of a few years ago, most practices weren't using these tests very often, and a few were kind of in the middle here. And then there were a handful that were using these tests a lot. And that's, I think the uses climbed somewhat, but that's a pretty good picture of how often these tests are used in clinical practice. And we looked and we said, well, is it changing management decisions? And so across about 1,500 patients with lower risk prostate cancer, where there's a question of, well, should I should I do surveillance? Should I undergo primary treatment, meaning surgery or radiation? And we looked and said, okay, well, what proportion of patients continued on surveillance if they had a test result above threshold, an elevated test? And it was about 46%. What about below threshold? So a low risk score, that was about 76%. So more patients, as you'd expect with a lower score, did elect for surveillance, and patients who didn't undergo testing at all were somewhere in the middle. So you could look at this and say, wow, these tests are informing decisions, so that's helpful. But you could also look at it and say, well, why are we getting a test if we're not really using it? So, for example, if a patient has a test that's high and elects surveillance, maybe that test wasn't that helpful after all. So both of these arguments are really important, and we're trying to understand better. We actually have 2 randomized clinical trials studying these tests. One has completed enrollment. This is called G minor. And so this enrolled patients after prostatectomy. They were randomized to undergo one of these tests or not. And we're understanding, we eventually, we will be able to analyze these data and understand how did it change the test, how did it change management decisions, and did it impact overall outcomes. We have another randomized control trial that's enrolling now called G major, where patients with newly diagnosed prostate cancer, again, are undergoing one of these tests or not in a randomized fashion. And this is the way that we really can understand how these tests might impact management decisions, how they might impact outcomes. And these data will take years to really come to fruition, but it's a little bit of a shout out to those of you who have thought about clinical trials or are participating in clinical trials, because it makes a huge difference. And this is how we understand for future patients how to optimize the tests we send and our ultimate management recommendations. We put together a guideline for how biomarkers should be used in localized prostate cancer a couple years ago. A number of us got to, through ASCO, which is a big clinical oncology society. And, a really important take-home message was, yes, these tests are helpful, but we shouldn't just always send them reflexively, because we really, in general, should only be using tests when they might impact management decisions. And so this is why we don't just automatically get a test like one of these 3 tests. Routinely, we generally restrict it for when there's a decision to be made that the test result might impact. Okay, so in the last part of this talk, I want to talk about the inherited side of things, which is germline genetics. And this is incredibly important in prostate cancer and has been, remarkably, I would say, underplayed over the years because of just lack of knowledge. And when we think of the gene BRCA, which actually stands for the breast cancer gene, we think of breast cancer, obviously, or ovarian cancer. But it turns out to be just as important in prostate cancer as it is in breast cancer. And so the word is getting out. This was covered a couple years ago in the Wall Street Journal, the genetic tests some men don't know they need. And so why is this important? Well, we learned in a major New England Journal of Medicine publication about 5 years ago. So NEJM is kind of the top of the top for medical journals. A big publication that showed that among men with metastatic prostate cancer, over 10% had an inherited mutation in their DNA that is associated with potentially causing prostate cancer. And so that's really important. That's a pretty substantial number. And if we look in another study that included mostly localized prostate cancer patients or patients with localized prostate cancer, we found similar results. And so I'm comparing the 2 studies here, which is why there are 2 figures, but about 17% of men in this second cohort of patients had a mutation in one of these genes that's inherited. And what's really important in both settings, in both reports, the gene BRCA2 was the most common inherited mutation found. So many patients carry these genes, and BRCA2 is the most common one. And you've already seen one of these figures. We call it a Kaplan-Meier plot that shows the probability of something happening over time. And in this case, it's metastasis-free survival on the left or cancer-specific survival on the right. And this is in a cohort of patients with localized prostate cancer who were treated. And in orange are patients who carried one of the BRCA genes, BRCA1 or 2, and in the blue are patients who did not. And so being higher on these is better because that means that over time, there are less cases of patients having a metastasis or less incidences of patients dying of prostate cancer. So the take home on this is that these genes are frequently seen, and having one of these genetic mutations in BRCA1 or BRCA2 really in particular can impact prognosis. And so there are guidelines from the NCCN around who should be recommended to undergo germline genetic testing. Both the prostate cancer guidelines and these genetic and familial high-risk assessment guidelines speak to this. Amazingly, this one doesn't have prostate cancer in the name, but it still has a lot of information and guidance around prostate cancer. Would love to see that change for the NCCN folks on here. So here are the recommendations in these guidelines. And what they are, that men with metastatic prostate cancer, or what we call intraductal or cribriform histologies, which are different patterns that Dr. Lotan sees under the microscope, which can can indicate that the tumor is a little bit more aggressive than we expect, or patients in that higher risk category that she described. So those are all indications for consideration of germline testing. There are family history and ancestry indications, so patients with prostate cancer and relatives with breast, ovarian, pancreatic, or metastatic or high-risk prostate cancer. And Ashkenazi Jewish ancestry is another risk. And then this last one is that sometimes we identify mutations in the tumor that we think might be specific just to the tumor, but if they look like they're in one of these genes that is sometimes inherited, that can actually be an indication that there's an inherited gene mutation as well. And so that can be a reason to undergo germline genetic testing. If I were to just kind of summarize these in a way that I think is a little kind of step back and say, like, how do we use this clinically? When do we have this conversation in our clinic? It's for patients with lower intermediate prostate cancer, if they have a really strong family history of one of those cancers that I mentioned, that where hereditary risk is really important. Or if a patient without family history has metastatic prostate cancer or high-risk localized prostate cancer, that is reason enough to have that discussion about germline genetic testing. And the last piece of all this, and we can maybe go into more detail in a Q&A session if folks are interested, is like, how is germline genetic testing done? Who orders it? How is the test result provided back to patients? These are all really important things, and there are a lot of different ways of handling that. But what I will say is that there are certified genetic counselors. So there are professionals who specialize in genetic education, both in pre-test counseling, deciding to get one of these tests, and in post-test counseling when there's a mutation identified, because it extends beyond the cancer. It extends to potentially risk of other cancers to family members. And so it's really important that we are able to work with these genetic counselors to help take care of patients in the best way possible. And so just kind of the key, I think, take-home points real quick are just we have these gene expression tests, genomic tests that we can order and use based on the tissue that we've already removed based on a biopsy or from a surgical specimen. They're not inherited, and they can help us understand overall risk. And then there are these germline tests, and those use usually either saliva or blood. And this is looking for something different, but it can be very important both in terms of informing prognosis and informing hereditary risk. So thanks so much, and I'll turn it over to Stan.
Great. Thank you. Thank you very much, Drs. Lotan, Dr. Morgan. Great presentation. So what I'm going to talk about today is decision-making. Just to lead this discussion off, I want to mention that I run a weekly prostate cancer support group. I get calls from men every day, and probably the most often question that I get is, how do I decide what to do? And so we'll talk today about making individualized treatment choices. There are pros and cons to treatment choices, as there are most things in life. The pros and cons are different for different people. And in the words, personal preferences is probably the best way to put it. And every man is different and has different personal preferences, and that's going to help them decide what treatment they may have. So, the doctor suggests treatments. We've heard about cancer risk, grade, volume, PSA histology. Dr. Lowton talked to us about looking under the microscope. Patient age and health is important. Patient preferences are equally important. And so we're going to talk more about patient preferences today. And again, the most often question that I get all the time, hundreds and hundreds of times, is why won't my doctor tell me which is the best choice? And often there are several good choices. The decision is yours. This session will focus on how to decide on treatment choices when there are more than one good treatment for cancer control. That is, take radiation, take surgery, take some other modalities of treatment, and the doctor has assessed that they all have equal outcomes. In other words, the man will live the same number of years, hopefully, out to his normal lifespan, and you, the patient, have to decide, which treatment to have. Not an easy decision to make. All right. So personal preferences, again, there's no right or wrong answers here. In essence, the doctor cannot get into your head and know your choices for this side effect or that side effect. Your concern about bowel problems, or your desire to know the probable success of your treatment sooner rather than later, or your concern about erectile function, or even temporary urinary incontinence are some examples, and we'll go into some more detail. Let's move on. So here are some questions, and this is just a sampling of the questions you can ask yourself. So we'll use some examples here, and it may, help clarify things. So with surgery, a question about all treatment decisions, not just surgery. Surgery versus radiation is what's shown here, and also brachytherapy, and just being on active surveillance. The question is, how important is it for me to have my entire prostate examined to know the extent of my disease in prostate and seminal vesicles, per what Dr. Lowton talked about. So when you have surgery, and only with surgery, do you remove the prostate, slice it into these small sections that Dr. Lowton told you about, and actually see what you had? You only know that, by what happens with the other treatments, what happens in a year or 2 years and 5 years. But here you kind of know right away after surgery. So that may be important to you, it may not be important to you, right? Talk about minimizing time for work. I have a dentist in my support group, for example, who, turn off my phone, sorry about that. I have a dentist in my support group who runs a small dental firm. It's very important for him to be there every day. He can't take off any time, and he needed to be treated, and he had his choice of radiation or surgery. He chose radiation because he could schedule his daily radiations. 40 treatments is what he got, early in the morning, 6:30, 7 o'clock, and still get to work and see his patients and have a whole day at work. All right. So we get into also discussions about how important is it for you to have natural erections, not to have to use any kind of aids, whether it's Viagra, Levitra, Ciala, or vacuum pumps or injection therapy. That's less or more important to men. So these are some ideas of questions to ask yourself that the doctor really, again, can't get into your head and know what your choices are. Here is another way of presenting the same data by pros and cons. Let me turn off. I really apologize for this. I've got so many things going here. My phone is going, so I apologize. So even with advanced prostate cancer, you can also choose your treatments. So, but here are pros and cons of radiation therapy. So there's no surgery involved if you're a person who doesn't want to have surgery. or is afraid of anesthesia, or for some reason can't have anesthesia, maybe heart problems or whatever. Incontinence is much less likely than surgery. Erectile problems, you still have them, but delayed. They could take 2 years to develop, and so forth. So you can read through these. And then there's the cons. Again, you have to wait more than a year to know whether you're a good chance of being cured or not. With surgery, for instance, and you'll see that in the next chart, that you can know right away because you watch your PSA and it should be undetectable right away. So again, personal preferences. Here is the pros and cons of robotic surgery, or even open surgery, non-robotic, kind of the same thing. As Dr. Lowton said, your prostate is analyzed right away. You know your PSA right away, or after 6 or 8 weeks after the PSA has cleared from your body. And it can be followed by external beam radiation if it's required, right? Again, excellent outcomes for surgery as well as radiation, more or less equal, for a localized prostate cancer, and even some intermediate stage prostate cancer. So, there's a 4 to 6 week recovery time, which may not work with your lifestyle. You're in the hospital for a couple of nights and so forth. You have a catheter. So you look at these pros and cons, and you discuss with whoever you discuss these things with, your partner, your family. And so I was talking about localized prostate cancer, and I'm saying even with advanced prostate cancer, you can often choose your treatment based on side effects, how aggressive you want to be. If you've tried chemotherapy, for instance, how well you tolerate it, then you're the one to decide, whether to continue with treatment or not. So in summary, many treatment decisions are personal. It's up to you. The importance you place on lifestyle choices and their consequences really can only be known by you. You're the best one to decide what to do. And a good conclusion to your doctor's appointment, which I always recommend to men, besides other questions that you should be bringing along to your doctor's appointment, along with someone else, another set of eyes and ears, and maybe make a recording, is to ask the doctor, are there other questions that I should be asking? Because you may have missed something. And so thank you for that, and turn this back to John. I think we have a question and answer session coming now. John?
Thank you, Stan. And thanks to our other presenters, Dr. Lowton and Dr. Morgan. Now it's time for our question and answer part of our webinar. And now I'm going to turn it back over to Stan, who is going to moderate the question and answer segment.
The first question I think should be best addressed to Dr. Lowton, and it has to do with whether the cancer is in a well-formed little place in the prostate, or is it uniformly distributed throughout the prostate?
That's actually a great question. So it varies, actually. Some patients tend to have a very well-formed nodule that you can see easily under the microscope, and some patients have a more sort of sneaky, infiltrative tumor that sort of grows in and between benign glands. One important point, which I didn't mention in my talk, is that many patients, maybe even as many as 40%, have more than one tumor in their prostate. So it's a kind of an unusual organ in the sense that you tend to have multiple, you can have multiple simultaneous and often independent tumors in the prostate. And researchers are still trying to understand what it is about the microenvironment in the prostate that makes multiple tumors arising simultaneously more likely. But pathologists just grade the largest, highest grade tumor, basically. And so that's typically what you'll see on your pathology report after a radical prostatectomy is description of the highest grade nodule, which is almost always the largest one as well.
Thank you, Dr. Lowton. Next question is really good. They're all good.
I know.
But this question has to do with transperineal biopsies. So, this is through the perineum, rather than through the rectum. And Dr. Logan, could you talk to Dr. Logan, could you talk to that as well as a two-part question, and that is, does NCCN have a position on transperineal biopsies?
Yeah,
Dr. Morgan?
I can happy to take that. So the NCCN does not have a position, I don't think. They're both acceptable from the NCCN standpoint. I would say in general, the urologic community has moved very steadily towards transperineal biopsies. And so just as you described, that transperineal biopsy does not go through the rectum, as you might think, biopsies which have always gone through the rectum historically because it's the easiest route to the prostate when we use the transrectal ultrasound to visualize the prostate. But those biopsies that go through the rectum put patients at risk of infection, and the risk of severe sepsis is in the range of a couple percent, 1 to 2%. Transperineal biopsies lower that risk to less than 0.1%. The challenge is that they're technically a little bit more challenging, and they can maybe be more painful, although there's some debate about that. In the state of Michigan, there's been again, we have this quality improvement collaborative called MUSIC that almost all urology practices participate in. There's been a real steady movement towards transperineal biopsies. At the University of Michigan, the last 3 years, almost all of our biopsies are transperineal.
Thank you. Excellent. So either Dr. Morgan or Dr. Lowton, the question is about multiparametric MRIs versus mpMRIs. So if you don't have an if you don't have a multiparametric MRI, is a bpMRI acceptable?
I can take that since it's kind of a urology topic. So multiparametric MRI uses contrast. Biparametric MRI does not use contrast. And so the advantage of biparametric MRI is that it's cheaper and maybe easier to perform. The disadvantage is that multiparametric means that there are lots of different parameters that are looked at, and it's very technical, but the number of parameters goes down from 4 to 2, basically 4 with multiparametric, 2 with biparametric, but it seems to work almost as well. To answer this question, is the MR guided biopsy can still be performed using that biparametric MRI as long as there's a lesion that was visualized.
Thank you very much. The next question is from a man who had, he was going to have what sounds like a combination of MRI and biopsy. And the doctor just ended up doing the biopsies without any imaging and found Gleason 6. And he wants to have the imaging done. The doctor told him you better wait a while because the biopsy disrupted the tissue. So the question is, how long does he need to wait so that he'll get a valid MRI?
Proton, what do you think the recommendation would be at Hopkins?
Yeah, I'm trying to remember because I've heard our radiologist comment on this multiple times. I think it's on the order, it's definitely like 6 weeks plus, something like that. Maybe even a couple months if possible, because what happens is after the biopsy, you have some hemorrhage, some bleeding in the prostate, and that makes it very difficult to read the MRI.
Here would also be about 4 to 6 weeks. And then the question is, how likely is it to spread? The answer is that we will know better, whether a higher grade cancer was missed once an MRI is done. And so it's pretty common that a Gleason 6 or somebody has a Gleason 6 score on a biopsy without non-fusion guided biopsy, and that's okay. That's kind of the initial signal. And then the next thing is to get an MRI if it wasn't already done, and then do the MR targeted biopsy if there is a spot on MRI.
Okay, I'm trying to get to all the questions because I think we have time to, and I'm not sure I understand the next question. I'll just read it. Is there a time value for intermediate, moderate, and aggressive? Do either one of you physicians understand that question?
Yeah, I'm not sure I understand that.
All right, maybe.
I think a question that we often get is, and maybe this is what this is getting is like patient who has intermediate risk disease or high risk cancer, like how much time do I have to make a decision on treatment? And what I always counsel patients on is that these decisions are challenging, and the most important thing is to make a decision that you're comfortable with. And so to get the information, and if you need a second opinion, and get the second opinion. If you haven't, if you've seen a urologist and not a radiation oncologist, go see the radiation oncologist. Make sure you're fully educated, that you've watched this webinar in particular, but gotten the educational material to help you feel confident in your decision. There's no question that like with lower risk cancer, there's a lot of time to make a decision, and with higher risk cancer, like a Gleason 9 or 10, we do want to kind of move towards a decision, relatively sooner rather than later. But there's still ample time. What I also tell patients is probably this cancer has been there for a while, and so a few weeks here and there are not going to make a difference.
I'm so glad you answered the question that way, whether it was what was asked or not, because it's always being asked by patients, how long do I have to make my decision? So thank you. The next question seems to be asking whether an mpMRI is worth it. The PI-RAD grade, does that help in making a biopsy decision? So maybe Dr. Morgan.
Yeah. So the PI-RAD grade is how MRIs are scored, and it does not have anything really to do with how aggressive or not aggressive the cancer is. The first question: is there a spot that the radiologist sees? If there's a spot, it's going to get at least a PI-RAD 3. So 1 and 2 are negative, and then there's 3, 4, and 5, and basically it's how certain are we that that spot is going to be at least Gleason score 7 cancer. And because Gleason 6 prostate cancer is so low risk that we don't really necessarily think about trying to detect Gleason 6 prostate cancers. We really think about, we want to make sure we're finding the higher grade prostate cancers. And so a 3 is like an intermediate likelihood, 4 is a little bit higher, and 5 is really high likelihood of finding cancer there. And so that's what the PI-RAD score is telling us. And so it is quite accurate. MRI misses about 10% of high grade cancer. So about 10% of patients will have a negative MRI. 10% of patients with high grade cancers will have a negative MRI, which is pretty darn low.
Yep.
So in general, very reassuring.
Terrific, thank you. All right, our next question has to do with the spread of prostate cancer to the lymph nodes. First of all, I would just like to hear myself from Dr. Lowton about, you look at lymph nodes that have, been given to you, and how is that done? How's that histology done any differently from the prostate tissues itself? And then how to treat lymph nodes, which go back, infected cancer found lymph nodes, back to Dr. Morgan. So Dr. Lowton first.
Yeah, so we get in most or many cases we get lymph nodes that the surgeon removes, usually from both sides, pelvic lymph nodes embedded in fat tissue along with the prostate. And we examine these separately from the prostate, and we keep the left lymph nodes separate from the right lymph nodes most of the time, so we know what side we're looking at. And we usually actually just embed all of the tissue we receive, and because it's very hard to find these nodes, they're often very, very tiny or very, very fatty themselves. They get kind of infiltrated by fat. And we look at those under the microscope to see if we see any prostate cancer glands in them. A lymph node normally just contains immune cells, so lymphocytes typically, which look very different from prostate cancer cells. So we look to see if we can see any prostate cancer cells spreading in those nodes. And if so, we often measure how large they are. Typically, they're quite small, because if they were large, they would have often been seen on imaging before the prostatectomy, and many of those patients don't ever get surgery. So nowadays, we see typically very, very small metastases, less than 1 millimeter large, and then report them. And of course, that increases this patient's stage. Now they're considered to be N1, so they have a tumor in their lymph node.
Thank you, thank you. And Dr. Morgan, how about treatment?
Yeah, so treatments change at that point. And the reason is, once cancer cells have spread beyond the prostate, whether it's to lymph nodes or to bone or anywhere else, then typically just removal or just radiation isn't going to be enough. And the most common treatment we use is some form of hormone therapy that blocks testosterone. And there are multiple ways that we do this, and that allows the whole body to be treated because that medication acts throughout the entire body. And so it's say if we've we've done surgery and there were lymph nodes found to have cancer in them, then we tell the patient, well, that was step one of treatment. It's highly likely that more treatment will be necessary, and sometimes it's like just right off the bat we say more treatment is needed, and that can be radiation. It can, and almost always is going to also entail hormone treatment.
Thank you very much. So I'm going to skip some of the questions and then come back if we have time. And John, you'll tell me what our time is looking like. But this question gets asked so much that I want to ask Dr. Morgan about it, and it has to do with proton therapy, the pros and cons. They do a lot of advertising, so just give us relatively summary of what you think about proton therapy versus, of course, photon therapy, the normal external beam.
Yeah. So great. So in general, for any patient undergoing, with newly diagnosed prostate cancer, localized prostate cancer, I recommend a visit with a radiation oncologist. And the radiation oncologist is going to really be able to provide the best information about proton treatment. What do we broadly think about proton treatment? It is likely effective, but it is likely no more effective than standard, which doesn't sound as sexy, but it's state-of-the-art, EBRT, external beam radiation therapy. And there are many different ways to administer external beam radiotherapy. And Stan, you use the term photon, and that it's a good word to use because proton sounds so good, but it's just a word. And photon is also different forms of energy. And photon. So a lot of proton is built on that, like the marketing, like you said. And again, we just don't. It theoretically could be better, but it's been around for decades, and there is no data to show that it's better. It does cost a whole heck of a lot more money. And there are definitely cancers that it is useful for. Prostate cancer so far does not seem to be one where it provides an advantage.
Thank you, Todd. Great summary. This is another good question. And again, it's, if we had a radiation oncologist, but I'm sure Dr. Morgan can answer it. So if the cancer reoccurs after radiation treatments, can the same area be radiated later on?
Yeah, so the answer is very often yes. There are kind of the two big branches of radiation that are given. There's external beam, where a patient will sit on a table at some point, and the radiation is invisibly, and you can't smell it or hear anything, but it's being directed at the prostate from the outside. And there's implantable radiation, known as brachytherapy, and there are a couple different forms of brachytherapy. Often, if a patient has gotten external beam radiation, then a subsequent treatment for recurrence, an option is a certain type of implant brachytherapy that can be given more precisely. Those patients, there are other options, sometimes freezing the prostate or using this thing called HIFU, high intensity focused ultrasound. So an ablation can sometimes be appropriate. For some men, a salvage, it's called salvage. It's not a great term, but it means treatment after treatment's already been given. Prostatectomy can be done, but patients say, well, why can't we just do radiation first and then surgery if the radiation didn't work? The reason is that there's a lot of scar tissue that occurs with radiation. That means that the side effects of surgery and the risks of surgery are totally different. And often those risks don't make sense because these other treatments can be used instead with lower risks.
Thank you. This question is clearly for Tamara, Dr. Lowden. Okay. Apparently this patient had in his biopsy report that this tumor displays mucinous features, multiple cystic structures, no discrete lesion, perineal invasion, and there are others. And maybe you could just run through the ones that you get the most questions about, or that that patients are asking their doctors about. What does this and that mean in my report?
Yeah, these are great questions also. So the most important information is in the Gleason grade, or the overall grade group, for sure. There are some descriptors that pathologists use almost more because they're talking to other pathologists who might be seeing that case as a second opinion, for example. So mucinous features does not have a clear prognostic implication, nor do cystic structures. So I would just ignore discussions like or terms like that. The terms that do probably add a little bit of additional information beyond the grade group are perineural invasion. So that means that the prostate cancer is actually invading around very small nerves that were sampled in the biopsy tissue. And the only place this matters is on biopsy, and it probably increases the risk that the tumor has spread outside of the prostate, locally outside of the prostate, into the fat that surrounds the prostate. So if we study patients who get biopsies with perineural invasion or no perineural invasion, and then they get a radical prostatectomy, the ones that had biopsies where we saw some perineural invasion were more likely to have tumor spread outside the prostate when we look at the radical prostatectomy. But again, it's not perfect. It's just a slight increase in risk. But sometimes surgeons and even radiation oncologists will consider the tumor slightly more aggressive if they see perineural invasion. The two other histologic factors that probably do make a difference, which Dr. Morgan mentioned them, actually are cribiform disease. And I don't have time to bring my slides back up, but that's just sort of these more complex structures that the prostate glands are making. That's all pattern 4 prostate cancer, but it's sort of a subtype of pattern 4 prostate cancer that we think is a little more aggressive than some of the other types of pattern 4 prostate cancer. So that probably bumps up the risk a little bit if you see that in the pathology report. And intraductal carcinoma, which just means the cancer is spreading within the normal ducts that live in the prostate. And that kind of spread also seems to be associated with a slight increase in risk. Again, it's not the same as bumping you up a whole grade group, but maybe thinking about it as sort of like half a notch up or something like that. So it might be factored into some decision making and might be associated with some additional germline genetic risk, like Dr. Morgan said.
Thank you.
I
Thank
can
you.
pull out a couple before we run out of time. There are a couple questions about germline testing that I'd love to address.
Please do. Just go do it.
I'm gonna do it. So there's a couple questions. We should have 2 more hours because these questions are so spot on. We should make a list of these questions and make another video. So I missed the significance of BRCA. I'm reading a question. Missed the significance of BRCA as it applies to men. Does the presence of that gene mean you're susceptible to all forms of cancer? It means that you are susceptible to many forms of cancer. And ones that we really clearly know about are breast cancer. So for a guy, it's still breast cancer, but also their sisters or daughters are breast and ovarian cancer, pancreatic cancer. We talked about prostate cancer, colon cancer. So breast, ovarian, did I say them all? Prostate. Tell me if I missed one. So multiple really important cancers. So that's a yes, there, but not all cancers. And so then there was a question of so for somebody who has a mutation in BRCA2 without prostate cancer, what do they do for early detection? We would recommend PSA testing starting at age 40. There's a study, we're running a study here actually that starts at age 35. There's a study we're working with the NCI on a study that also incorporates MRI. So for this person who asked the question, if they have a BRCA2 mutation and they're 35 and no diagnosis of prostate cancer, you can actually go on the NCI's website. They will fly you out annually for prostate cancer testing. So that's for free. And so you have that benefit plus really major contribution to an important clinical trial. But we would say earlier prostate cancer testing and lower PSA threshold. So a lower trigger for biopsy. And then somebody else highlighted a really important study, which is being led by Dr. Heather Chang at the University of Washington, Fred Hutch, called the PROMISE Registry. So PROMISE, you can go Google search the PROMISE Registry and Heather Chang. And that's a registry where germline testing can be done for patients with appropriate indication, certainly at least metastatic patients with metastatic prostate cancer, and there's education all done virtually, and then free germline genetic testing. So thank you for all those questions.
Thank you very much. I'm going to keep going as long as we have time, John. So a question definitely for Dr. Lowton is, should I send my slides off to John Hopkins for a second opinion? Tamara?
Right. Well, I'm definitely not going to just pitch Johns Hopkins. There were a couple questions about second opinions. Obviously I'm biased because I'm a pathologist, but I think that is often useful. I think actually for many things in medicine, it's worth getting a second opinion. And you should never worry about offending your doctor, in doing so. For pathology in particular, because it's so critical and it often is kind of driving a lot of these treatment decisions, I think that is often worthwhile. But it doesn't have to be done at Johns Hopkins or many other centers that do excellent second opinions, Memorial Sloan Kettering, MD Anderson, University of Michigan, many other places around the country. Just any place that sees a high volume of prostate cancer would be a good place. Just because pathologists are human, and as you saw from the diagram I showed you, we're trying to sort of integrate all these different shapes that we're looking at under the microscope into this overall score. And we don't always agree 100% of the time. Most of the time we do, but not 100% of the time. So getting an opinion by a pathologist who really specializes in prostate cancer or GU pathology and spends all their time looking at prostate biopsies, I think can be valuable. Many pathologists see all kinds of tumor types, colon and breast. And as I mentioned, they all have their own grading systems. And so it's hard to be completely expert in all of those nuances. So I think any place where they have a dedicated GU pathologist, and a lot of good urologists and urologic oncologists is a good center for second opinion and worth doing, and often paid for by your insurance.
Thank you. And Dr. Morgan, if someone asks you to recommend someone to get a second opinion, you're not insulted.
Yeah, no, I encourage it. I get it. I've been, the other side of things, you don't want to impact that relationship you have with your care team, but I always reassure patients it doesn't. Patients do this. This is good. Get a second opinion. It's just, and who cares about anybody else's feelings anyway? It's you're the one who's going through this.
Yeah, thank you. A doctor the other day told me that he was surprised when people didn't ask for a second opinion.
Yeah, do it. Get a second opinion. It's appropriate.
Okay.
So, you're only going to learn more.
I want to go down to what we call hyperfractionation. That is, the old 40 external beam radiation treatments knock you down to 30 or 25 or even fewer. You want to say something about that, Dr. Morgan?
Yeah. This is what the kind of the broader field of radiation oncology has been working to improve technology, to improve how accurately can the beam target the prostate with as little collateral damage as possible. And the more accurate that beam can be, then the more radiation dose can be given each time. And so radiation, we actually think of it like as a cumulative dose, and we want to get that radiation dose up to a certain level. And historically, that has had to be just spaced out by little increments. And so it was 40 treatments, and then it got better, and we could do 20 treatments. And now it's down to, for many patients are eligible for a form of radiation that can be done in 5 treatments. It literally could go down to 2, in the next 10 years. I don't know, but it's possible because of the increased accuracy and the better imaging that allows this. There are ongoing trials that are assessing whether it's appropriate that shorter course of 5 is appropriate for all patients, or maybe it's just patients on the lower and intermediate end of the spectrum in terms of risk. So I'd say, the jury is still out to some degree on people at that higher risk end, but in general, for most patients, that shorter course is very appropriate. It's I think surgery, people intuitively say, oh, I need a surgeon who is very experienced and has done a lot of prostatectomies. Of course, it's totally the same for seeing seeing a radiation oncologist. You want to see somebody who's got a lot of expertise and experience, and it makes a big difference.
Thank you very much. I'm going to jump down to this question. We can maybe generalize it. We don't give, specific patient information, but this particular patient's PSA is varying from 7 to 11. It goes up and down, which is puzzling because it's probably not caused by the cancer. Anyway, my urologist wants to do an MRI to check for cancer. My primary care physician says it was due to prostate cancer. The PSA wouldn't go up and down. Thoughts, I guess, Dr. Morgan?
Yeah, so this gets at this issue of PSA screening in patients without prostate cancer and how good is PSA? The answer is PSA is very mediocre as a screening tool. And the reason is that PSA, which, like a very broad, like rule of thumb, which is too broad, but a broad rule of thumb would be PSA over 4 is high, is elevated, and that patient is at risk of harboring prostate cancer that should hopefully be detected. But as people get older, the prostate grows usually due to BPH, benign prostatic hyperplasia. And as the prostate enlarges, the PSA just goes up for benign reasons, not because of the cancer. And so it does become less accurate, especially as people get older. And PSA varies from day to day. It varies from one lab to the next. It goes up with sexual activity. It can go up with riding a bicycle. And there's just natural fluctuation from one time to the next. Who's right? They're both right. Your PCP is correct that my concern is kind of down because of that fluctuation. It goes to 11, then it goes back to 7, and yet, not knowing anything else, obviously, but somebody comes in with a PSA of 10, and a repeat check is also around there, 8 or 9. I'm going to recommend an MRI. Not a biopsy yet, but an MRI to help understand could there be prostate cancer in there that we should be trying to detect.
Excellent. Talking about MRIs, this person submitting the question, I'm sure, is not the only patient with a pacemaker or for some other reason can't have an MRI. So are there other methods of determining the size and risk of cancer locations? Dr. Morgan?
Yeah, there is, and I don't have any experience with it, so I can't really speak to it, but there's new these micro ultrasound that gives a much higher definition ultrasound picture of the prostate, and a few centers have started using it so far as an adjunct to MRI, but potentially if it is good enough as an option for all patients or patients who, nobody loves having an MRI, of course, it's claustrophobic. Nobody loves having transrectal ultrasound either, obviously, but that is an option at centers that have that tool, which is starting to gain some traction.
Good. Dr. Morgan, should a patient who visits his GP yearly insist on having a digital rectal exam?
So I would defer to the early detection guidelines on this, which are a different set of guidelines. Early detection should be done after a shared decision-making process with a PCP or urologist, meaning understanding the pros and cons of testing. PSA is the linchpin of early detection. It doesn't mean that a patient with an elevated PSA needs to go right to a biopsy. In fact, we usually would recommend against that. We would say if PSA tells us that somebody is at higher risk, maybe and should undergo either additional biomarker testing and or an MRI, and then use that to make a decision about a biopsy. Are there patients who have a low PSA and who have a nodule where a digital rectal exam would pick up a prostate cancer that the PSA would miss? Yes, absolutely. It is the minority of patients. I, in general, would say that a digital rectal exam in a healthy male of the screening age, which is roughly 50 to 70 or 75, or a patient with a family history or a known mutation would be started at age 40, should have a digital rectal exam roughly every few years. I don't think it is the most important thing by any stretch of what we do to detect prostate cancer.
Thank you. Thank you. Thank you all.
Sorry to say we're out of time for today. I do need to mention that the NCCN Foundation thanks its corporate supporters. This webinar is supported through contributions from AstraZeneca and an educational grant from Janssen Biotech, administered by Janssen Scientific Affairs. Lastly, thanks again to our speakers, and thanks to everyone for attending. And we hope you receive some good information and encouragement. Have a good day. Thank you very much.
Thank you.